My talk was focused on the novelties in treatment of lower-risk MDS. Not only that, but also in the way we conceive and we categorize lower-risk MDS. Because now we have three possibilities, three systems: the IPSS, the old one that should be obsolete, the IPSS-R, and the IPSS-M, including molecular abnormalities, the latter being the most effective one in categorizing patients. But on top of that, we have to consider clonal hematopoiesis and clonal cytopenias that are nearly MDS and should be considered in the big picture of it. Having said so, I have also to add that now we have the possibility to select patients better, given this prognostic system, to optimize therapy. Even old therapy can be refreshed. Lenalidomide is the standard treatment for del(5q), transfusion dependent, but we show that when you reach a complete response in terms of cytogenetic, you can also in some cases stop treatment, keeping response. Now this is a preliminary observation we have to confirm. In a larger number of patients, we consider only 118 cases, so it has to be considered. And also lenalidomide can be used differently, not waiting for transfusion dependent in MDS del(5q), but giving a lower dose as soon as anemia becomes symptomatic. This was an observation by the Spanish group indicating that the transfusion dependence comes much later if you start early treatment. And starting early, it's a password for lower-risk MDS. Also, the use of luspatercept approved for transfusion-dependent MDS-RS in Europe and is now enlarging the label. So we will have the possibility to treat patients who are transfusion-dependent independently of their classification, with or without ring sideroblast. In first line, as soon as a patient becomes transfusion dependent, you can choose now between ESAs or luspatercept. And this is really a step forward because luspatercept guarantees a higher percentage of response in terms of transfusion independence. And not only that, another new drug that has just been approved in the US, not yet in Europe, is imetelstat, that is supposedly a telomerase inhibitor, and it is very active in inducing transfusion independence, even in 18% of cases longer than 1 year. And these again in patients with heavy transfusion need, lower risk MDS. So I think we have several tools that we can really apply to the lower risk MDS.